All right, here we go. Another example is, how about this? A 63-year-old female with altered mental status noted for a salicylate level of 110, okay, and it had an elevated CK. Well, let's do this competition right here. Let's do this competition of who's had the highest CK that they've seen. Well, I can give you one. I have one. This is during post-COVID, 300,000 a CK, and you say, how is this possible? Well, this was a gentleman who used to be very active prior to COVID. During COVID, became very inactive, which was seen by a lot of people. Watched a lot of YouTube, we'll go back in time, watch a lot of Tiger King, and whatever shows he wanted to watch. And he happened to drink a little bit too much alcohol, became out of shape, then decides, I'm gonna be back to the same shape I was immediately prior to COVID without any training. So he did a thing called the MRF. And why am I telling this? Because your patients may do the MRF, and they may have an elevated CK, and you may need to how to treat them. So he was so, how do you want to say, inflamed that he could barely move his muscles like this. He was like this. He was like the Tin Man going down the hall. So what is the MRF? The MRF is a 1 mile run, 100 push-ups, 200 push-ups, 100 pull-ups, 300 air squats, and a 1 mile run with 20-pound body armor. And you can repeat this until you basically die. This gentleman did this and had to stop because he had such pain, he couldn't move his arms the next day, and he came in and he had an elevated CK level of 300, above 300. Okay, so let's go to this individual with the salicylate level of greater than 110. Remember, levels of 30 can be toxic. Levels of greater than 100, we would do hemodialysis. Remember, we're going back and we're adding things to the things we talk about. But in this case, we're going to talk about this patient. They have an elevated troponin, okay, elevated CK. We talked about the MRF, and I told you my highest CK. Let's hear what yours is. And then this is what we're looking at right now, refractory shock. Refractory shock, meaning we cannot get our pressures up with fluid hydration, okay? So what are we going to look at? Vasopressors. Vasopressors. And we're going to talk about first is a Cochrane review. What is Cochrane review? Is a systematic, comprehensive summary and assessment of all available research and a specific healthcare question produced by a global organization. This organization is supposed to be free of any biases. So it's supposed to be a very high level of evidence. So this is a meta-analysis. We're taking all the studies and we're combining them together to get to the super study. And usually they do an amazing job. And what did they tell us on pressors? This is very important, very, very important. No evidence of substantial difference between vasopressors. There's not great studies, so there's not great evidence. Dopamine increases the risk of arrhythmias compared to norepinephrine and might increase mortality. That's the only good study that's really out there. Really, really out there is this one, the dopamine with the norepinephrine. The dopamine versus norepinephrine. So I know that everybody says that norepinephrine is the greatest. Guess what? You go back in the literature 10, 20 years ago, it wasn't. There was a certain brand name and it says a certain brand name, leave them for dead, okay? And you can figure out that rhyme on that. Certain brand name, leave them for dead, okay? And that's norepinephrine. It used to be garbage. Now it's the greatest, from worst to first, okay? And dopamine used to be the greatest before the study came out. But on the other part of this, no substantial evidence between the difference between the vasopressors, okay? Let's get with this other, let's get rid of this dogma, low-dose dopamine. Low-dose dopamine does not help renal perfusion. I know that you're going to have providers that say that. I know that you're going to have your textbooks, your board reviews, they're going to say low-dose dopamine can help renal perfusion. It does not. It does not do that. Low-dose dopamine can worsen renal perfusion in patients with an AKI. Here you can look at this right here, this study right here, low-dose dopamine worsens renal perfusion. This is on, you can look at this at multiple sources of literature. Let's end this dogma and let's get to the correct dogma. All right, so let's talk about the different vasopressors and what can increase our systemic vascular resistance. So at the high end, so let's go from the bottom up, dobutamine really doesn't affect the systemic vascular resistance. Now, do remember is that we have a full pressor lecture that you can go through and gives you full details on the pressors. This is just a quick overview so that way you can go and pass your boards. But if you really want to do a deep dive, we have that available for you. Dopamine itself is going to be next up for increasing systemic vascular resistance. Epinephrine gives a little bit more. Norepinephrine And norepinephrine, it does because it has an alpha receptor, LA1 on there. Vasopressor is next, and then phenylephrine, this is going to be our top where increases our systemic vascular resistance, causing constriction. What do we worry about when we increase our systemic vascular resistance? Is we can constrict and we can have ischemia. Now, what's the ones that are going to increase our cardiac output? We're still talking about Our Lady right here, that a 63-year-old female with salicylated overdose and toxic level, we know that her level's above 100, and we want to consider hemodialysis. If it was above 30, it's a toxicity, say between 30 and 100, and we don't have end organ damage, we would consider using a bicarb drip because we want the bicarb to help us pee out the aspirins. All right, and we also talked about the CK and how I have seen a greater CK than you, and now we're on the refractory shock. We're talking about increased cardiac output in our pressors. Phenylephrine is going to give the least cardiac output. It just hits the alpha receptor, really does not hit the beta. Vasopressin is 2, it's going to be a vasoconstrictive agent. Norepinephrine, you say, well, norepinephrine, really? It doesn't really hit it hits the alpha 2, but it really doesn't hit the betas as hard as the others. The beta is going to give our increased cardiac output. Norepinephrine is stronger, and then dopamine gives more increased cardiac output up to dobutamine, where it's pure cardiac output. Peripheral vasopressors. Okay, so what are we talking about is, back in the day it was said, hey, once you have a vasopressor on, you immediately have to put in a central line. In fact, people wouldn't start on vasopressors unless they had a central line. That's kind of an old dogma too. If you can do specific criteria and hit this criteria, you can use peripheral vasodilators, and it's going to be certain doses, certain types, for a certain extended period of time, and then if they're still on there, you may need to consider putting a central venous catheter. What is the purpose of this? The purpose is to reduce the amount of central venous catheters, because what can happen? We can have complications on placement, complications in management, increased risk of infection. So if we can avoid those, this is a better thing for the patient. So peripheral vasopressors and central, we talked about you can have complications in placing a central venous catheter. In a peripheral, this is new safety data. We're breaking dogmas. We're saying is that if we have a peripheral IV, 18 to 20 gauge, above the wrist and below the antecubital fossa, so antecubital fossa, this is your wrist in case you forgot about it, wrist. So somewhere in here is going to be okay. Place with ultrasonic guidance. Remember how we talked about how the ultrasound is becoming the mainstay of care in our healthcare system. Someday you'll have a portable one that will look like this. Maybe even your phone can do it. And yes, there's modules that can fit in your phone, and they're going to get cheaper and better over time. And you need to have the nursing. You have to have the nursing scheduled to have a check on that IV between the wrist and below the antecubital fossa every 2 hours. So you have to have a system in place. You just don't start doing this. You have to have a system because you have to involve all the teams, including nursing. So this is where a system approach to healthcare is the best. And this is where the protocol medicine comes in fact, because you unite and get all the areas of healthcare together in a protocol-based medicine where you can work together. So the max dose of norepinephrine could be 0.15 to 0.7. This is the best study. Maybe not using vasopressin. Maybe no vasopressin because that can be a vasoconstrictor. Max for 48 hours. Patient must be able to report pain or discomfort. So if they're asleep on the vent like this, they cannot report pain or discomfort to you. Clear nursing-driven response protocols. So what do they do if something bad happens? And nursing and team education. So moving to peripheral vasopressors, in the studies, they had reduced amount of central venous catheter complications because you had less central venous catheters placed. About 3 to 4% had complications. Extravascularization, meaning outside the vasculature, rate of 2.3%, so with no tissue injury. Of the study that was done, 13% required to be switched over to the central line. So basically, within that 48 hours, these patients were able to become weaned off vasopressors and be able to go either to the wards or back home. So vasopressin probably shouldn't be used, and why is that? Because it does vasoconstriction, as we talked about, but it's not well studied, and there's no antidote for extravasculation. So meaning if it goes outside the vein, there is no antidote for us. So let's go, and then you can consider a midline catheter. Studies show no difference in catheter-related complications. And you need to have easy, accessible phentolamine and nitroglycerin, and we're going to talk about these. And if you have a second pressor added, you need to place the CVC. Okay. So this is a protocol to initiate for doing peripheral vasopressors. Remember, we have a full study on a full lecture on using vasopressors if you choose to go through. This is an example of a gentleman who had vasopressors outside, and you can see the swelling here, extravascularization outside the vasculature, and you can see these little dots right here. This is what they had injections. This was noted. Unfortunately, they had extravascularization. Guess what? They didn't follow the protocol because guess where the IV was right here? This is the antecutal fossa. So probably the IV was a little bit lower, so maybe not following the protocol exactly. So they put the phentolamine in. You can see these are where the little dots are. Boom, boom, boom. So let's talk about this. Okay, now let's talk about extravasculation of IV pressors. Okay, extravascularization of IV pressors. All right, let's take a look at this. What's the treatment? Phentolamine. Remember, phentolamine is an alpha anergotic blocker causing the blood vessels to relax. Right here, it's going to be therefore increasing blood flow to the affected area and preventing tissue death by caused by the vasopressor. One of else we use phentolamine is for phenochromatomas. Where can we see phenochromatomas? Here we're trying to get our other areas in. This is going to be our endocrine. It's going to be the MEN2As. We're going to have phenochromatomas, parathyroid adenomas, and medullary carcinoma of the thyroid. Then we can have MEN2B, some people call it MEN3 syndrome, medullary thyroid carcinoma, phenochromatosis, mucosa neuromas, and marfanoid habitus. So alpha anergic receptor blockade, also used for hypertension associated with phenochromatosis. You inject 5 to 10 milligrams diluted in 10 milligrams normal sodium chloride with 12 hours of the start of the insult. This is going to help the blood flow. All right, so extravasculation of pressors. Now remember, we're still talking about this lady. And we did all these things. We gave her, you notice she's hypotensive. We started on pressors. And then we did is we caused her to have extravascularization of the pressors. And then we had to give her phentolamine. And we still notice she has an elevated troponin and refractory hypotension. So she's taken to the cath lab. And what do we see here? So in the cath lab, this is this classic ballooning right here. Classic ballooning. See this right here? All right. Remember, this is a 63-year-old female with altered mental status with salicylate level that was elevated. We were greater than 110, so greater than 100, we consider hemodialysis. We'd also consider in patients with end-stage end-organ disease, maybe she was altered. Elevated CK, 160 with elevated troponin, refractory shock. So let's talk about Takotsubo cardiomyopathy. It is known as stress cardiomyopathy, is seen in transplant cardiac dysfunction, is a transient cardiac dysfunction and with apical ventricle ballooning caused by emotional behavioral stressors. Mimics acute coronary syndrome, presents with chest pain, elevated troponin, EKG changes, and ST elevation. Echo shows ballooning, and we're going to go back to that ballooning of the ventricle, dilations and akinesis of the left ventricle apex, while catheterization shows no significant coronary disease. Ejection fraction usually normalizes quickly. Treatment can be supportive. Sometimes they will get active treatment. Now let's go back and let's take a look at it. Okay, so see this right here, and it's called Takotsubo's because right here, Takotsubo would be an octopus trap, a Japanese octopus trap. This would be the jar, which would capture the octopus in there and has that ballooning like that octopus trap. So here's the octopus gets in there, they get trapped, and then we kill the octopus and eat it, okay? So Takotsubo's cardiomyopathy, remember the cardiac cath is clean. generally will normalize with, they may need treatment or they may not be treated, but they generally will normalize. Propofol infusion syndrome. So here again is we have this lady with the elevated CK. Should she get propofol? No, she shouldn't get propofol. She'd have to get another sedation if she was placed on a ventilator. Now she was ventilated because she wasn't protecting her airway. Remember we talked about protecting the airway. This all goes together. So this propofol infusion system can cause rhabdomyolysis, muscle necrosis, bradyarrhythmias, cardiovascular collapse, lactic acidosis, and multi-organ system failure. Now propofol is used for what? When we ventilate a patient, we have sedation on that patient. Is it an analgesic? No, propofol is not an analgesic. A lot of people will make that mistake and think that it covers analgesia and anesthesia. It does not. It does not cover pain. Propofol inhibits mitochondrial ATP production at high doses, blocks coenzyme Q, inhibits the function of the electron transport chain, and decreases ATP production, inhibits the ability of the mitochondria to use fatty acids as fuel. So propofol infusion system was something you used to see quite more often than now. Now there's protocols when you initiate propofol on, and I used to talk to the old school nurses, and they used to talk about they literally would go through a bottle of propofol on a lean patient every hour and just keep giving it and giving it. They'll say that the propofol use is much less now. We have protocols where you're following a CPK and you decrease or stop it when a CPK elevates. So you don't see the propofol infusion syndrome as much as you used to in the past. All right, here's the same lady, the same poor lady that we had that has 63-year-old female with altered mental status, noted for a salicylate level that was elevated. We're going to do hemodialysis because it was so elevated. It was elevated for an elevated CK. We said, oh, when we intubate her, we will not give her propofol because her CK was already elevated. And then she had a elevated troponin. We went and we did a cart cath. Her arteries, her coronary arteries were clean, but she was noted for the apical enlarging, so she had Takotsubo's cardiomyopathy. We should get supportive care. She may need management for the heart failure if it's refractory, but more likely is that she'll come back and she'll get better. Her heart failure, her ejection fraction will improve. And she had refractory shock, and we had that refractory shock. We gave her on vasopressors. We discussed the types of vasopressors, and then we also gave her, we infiltrated, and we gave her phentolamine because of the infiltration. Now we went to place a central line on her, and we gave her a pneumothorax. See this right here? This is not a fair x-ray because this is a chronic pneumothorax, meaning it's been around for a period of time, but this is a significant pneumothorax. So that's what you do is when you get this x-ray, you want to trace and you want to look for lung markings where there's no lung markings. In this example right here, you can see all the way through that there's no lung markings, a very large pneumothorax. And what do we want to do? How do we first know for pneumothorax? We have this x-ray here. What if we can't get an x-ray? What can we do? And this is where we start using our ultrasound. This is going to be an example. This could be a photo on here. So this one is going to show a pneumothorax, and I'll show you one with no pneumothorax. So basically, we're taking our linear probe and we're putting it on our chest. We can check it at 8 points on each side. So 8 points here, 8 points here, 8 points here, through the ribs, go 8 points here. And we're looking for a pneumothorax. We can do this with ultrasound. It has a high sensitivity to it. It has a high sensitivity, a high specificity. So this is a case where there's pneumothorax, and I'll show you. So we're using that linear probe. We go to M mode. M mode is where everything gets focused here. We're using this energy to look for pneumothorax. We'll have discussion on this later, but right here, this is a sign of no pneumothorax. And you can look at how you can tell the difference. So if they put a picture on boards, or somebody quizzes you on the wards or in the ICU when we're checking this out, this is called sandy beach. If you can see the sand right here, and you see the waves of water right here, there's no pneumothorax. Then we go back over here. This has a pneumothorax, has a barcode all the way through. So this is a simple way. We'll give more discussion on this. This is just to prep your mind to get ready for this. As we look and see there's a barcode and we have a pneumothorax. This is showing on M mode on this ultrasound probe that there is no movement. So there is a pneumothorax. Over here on the M mode, there's movement, and you're going to have what's called sandy beach. Now we put a chest tube in. You don't see the chest tube. It's not in properly, and it's over here, and we got rid of the pneumothorax, the chest tube got pulled out, and we have sub-Q air. Sub-Q air right here. So this is what a sub-Q air looks like on this poor lady who's gone through so much. So that's an example, a real-world example of a patient where a lot of things went wrong. All right, so talking more on this, we're concluding our critical care section, and we'll know that life happens, okay? Through your careers, you're going to see a lot of things, and the patients don't read the textbooks, and then things happen that shouldn't happen, and they do. Like I've seen whole times where someone's getting treated for DKA, and they did speed dating on the DKA treatment. Let's go back there, is they gave a whole bag of insulin all at once, and they bolused that whole bag of insulin. They gave a speed dating where we had to worry about what? So things we have to worry about, say, for example, if unfortunately, if a whole bag of insulin is being administered all at once in the treatment for DKA, is that we have to worry about what? Potassium, the potassium shifting inwards, so we have to make sure the potassium levels are okay, and then the glucose. So you can treat this. If things happen, we're giving you enough information that you can walk through these scenarios. If somebody gets a whole bag of heparin, we talked about this as protanamine sulfate. You will thank God for protanamine sulfate. Just a little bit, protanamine sulfate, you know what it's made from? Salmon sperm. Yes, it's made from salmon sperm. Look that up. Just a little bit of side information for you.